Hello, I'm Deborah Chieli, a nationally board certified nurse practitioner with specialty certification in lifestyle medicine.
And I'm Susie Spell, a nationally board certified nurse practitioner, also certified in lifestyle medicine.
The following interview was part of a series that informed our presentation at the 2023 Annual Conference of the American College of Lifestyle Medicine, ACLM, titled Nurses in Action: How Nurses Operationalize Lifestyle Medicine in Modern Settings, and You Can Too.
In this series, nurses from diverse backgrounds and practice settings and their champions tell their personal and professional stories about discovering lifestyle medicine and how they're implementing it across a wide range of settings.
Nurses are the largest health profession in the United States and globally, and have been voted the most trusted profession here in the U.S. for over 20 years. Learning about and incorporating the pillars of lifestyle medicine fosters full scope of practice and the ability to answer the call to lead by the National Academy of Medicine with their report, Future of Nursing 2020 to 2030, Charting a Path to Achieve Health Equity.
We hope these stories of success will inspire conversation and drive creative solutions to better address inequities in healthcare. Continued growth of nursing expertise in lifestyle medicine will expedite our nation's ability to address the public health emergency of chronic lifestyle diseases we currently face.
The power of nurses to create innovative solutions when combined with the practice of lifestyle medicine allows nurses to express their full potential while simultaneously addressing the salient issues of health equity, the epidemic of chronic disease, and the provision of truly patient-centered whole person care.
When nurses are empowered to lead with an interdisciplinary and multi-sector practice, they answer the call of the National Academy of Medicine to dissolve barriers to care and improve health for themselves, the nation, and every global citizen. Enjoy the interview. Today, I'm speaking with Dr. John Gobble. He's a registered dietitian and founder of the Lifestyle Medicine Group in Milwaukie, Oregon. He is a health promotion specialist and has been for over 30 years. He's on a mission to reverse chronic disease using preventative medicine measures. He's earned a doctorate of public health and preventative care and a master's in public health in both public health nutrition and health education from Loma Linda University's School of Public Health. And in addition to being a licensed registered dietitian, he's also a master certified health education specialist and a certified health and fitness specialist by the American College of Sports Medicine. And he's a certified intrinsic coach. So a lot of training and many, many years of service. He's also a member of the American Dietetic Association and on the executive board of the Oregon Dietetic Association, and is a member of the American College of Lifestyle Medicine, which is how I connected with him initially a few years ago. In addition to all of that, as if that wasn't enough, he was the task force chair on creating a reimbursement roadmap that was put out by the American College of Lifestyle Medicine for all kinds of providers in the health field to use in order to be able to get reimbursement for the services they provide within the framework of lifestyle medicine. Dr. Gobble, I'm very glad that you're here and talking with us. And did I miss anything?
Well, I'm very active in American College of Lifestyle Medicine as the chair of the Reimbursement Member Interest Group. As a result, I'm a diplomat of the American College of Lifestyle Medicine and fellow of the American College of Lifestyle Medicine. So it's like really into lifestyle medicine. So that's why we're the Lifestyle Medicine Group, which is a group of dietitians and health educators and health coaches that provide medical nutrition therapy and lifestyle change strategies for providers all over Oregon and Washington.
It looks amazing. Can we start at your origin story? Was there anything that sparked your interest in preventative medicine and then lifestyle medicine? How did that all start for you?
Oh, that all started many years ago with my wife and her mother were very involved in nutrition. Nutrition was very important to her. And so I said, I want to get into this family. I better know something about nutrition. So I went and took a college nutrition course. And it was like, that's really interesting. And as I studied more into it, I realized this has a significant impact. And yet people didn't value it. I can see more value here than most in the system. And so I went off and went to Loma Linda University and got a Master of Public Health and Nutrition And that's where I found out that, boy, this makes a big difference. And I met Hans Steele there, and he just showed how in the program he was working with Pritikin and some others, it just really made a difference, reversing diabetes and heart disease and stuff like. And I go, this has really got something go on here. So that got me started. I thought I better get as much information as possible. Got into the doctor program and been quite a journey ever since. Exciting things happening. And American College of Lifestyle Medicine grew out of all these kinds of people that, like myself, had this kind of interest to make it a moving force now in healthcare. So it's pretty exciting.
It was nice that you were just open to that idea and exploring it more and finding that it was of such value. So that's amazing. How did it come that you became more interested in or a leader for the reimbursement part of this?
When I graduated from my Master of Public Health, the dean of the school made us talk, and he said, you have a profession, like we're doing nutrition, health education. He said, but you need to find something else, something that you can hone in on in addition, because that can really make a difference later on in life. And so I had the opportunity to do a number of things. I got into building software for computerized health appraisals and corporate wellness with Dr. Don Hall in WellSource. Then in 2002, Medicare decided to pay for medical nutrition therapy. And I said, oh, here's an opportunity. So I built software to help manage all the data for that. And because it was quite a bit that they required to collect how much carbohydrate is a person eating, how much protein, all this stuff. And it's like, okay, EMRs do not do that. They don't collect this data, at least not that time. And I worked on that. And then I realized, how do you get paid? Okay, you got to create claims, but the insurance companies don't necessarily understand to pay for this, but they ended in 2011, most of them have to because of the ACA, Affordable Care Act, Obamacare. That just, it became a game to me. It's like a video game where you're trying to figure out how to get through that maze. And that's what reimbursement is all about, getting through the maze and how to get paid. And so for a nutrition practice, we're successful because I spent the time. But when a healthcare institution like a hospital or something tries to do nutrition and they get a denial, they just go, oh, well, we've got bigger fish to fry, not nutrition. It's a loser for them. And they say, oh, you can't make a living on nutrition. It's just sort of a lost leader. And that's the attitude. And I said, I beg to differ because we're doing fine. And I don't think there's very many organizations like ours that does this, but that's because I spent a lot of time figuring out reimbursement. And so then I became part of that reimbursement task force and a member interest group. And with the resources of ACLM, we've been able to learn a lot and publish. We got a journal last year in the Family Practice Journal and shared how lifestyle could be paid for by healthcare. Now we got more Medicaid getting on board, and I'm actually in a very good state of Oregon where basically anything nutrition related will get paid for.
That's really nice. Have you done a lot of work with teams or institutions that are utilizing nurses in the lifestyle medicine framework or that are practicing lifestyle medicine?
Yes, well, not only with my connections with American College of Lifestyle Medicine, but I also work with a family practice clinic. And one of the lead providers is a nurse practitioner. So working with her and the physician, he's a DO, and we say, okay, how can we do lifestyle medicine here? And we looked at the EMR and put together questionnaires that come from American College of Lifestyle. Again, American College of Lifestyle Medicine provides resources for this. And we incorporate that in the EMR, and then slowly and surely they began to do it. This nurse practitioner didn't have any experience in it, but because she saw the results, what impact it makes, then she says, oh, we got to do this. And then the physician and his partners, they all joined the American College of Lifestyle Medicine and became diplomats and so forth. Anyway, it's just grew from there. So that's a personal experience. But most importantly is that I market our nutrition services in classes. We do shared medical visits and so forth. We market this to about 1,000 providers in our community around in Oregon and in Southwest Washington. They see the results. And a lot of these are nurse practitioners as well as PAs. some of my most loyal referral sources are nurse practitioners.
Right. And a couple of questions I want to ask from there. And our colleague Deborah is here as well, who has a keen interest in being able to allow nurses to practice at the top of their scope. And there's a couple things you said I want to go into eventually through our conversation. And one is the different kinds of visits. You already touched on it a little bit, like the shared medical visits or telehealth and that kind of thing. But do you feel like this is a way that nurses could be able to practice to the top of their scope? Do you feel like this could be a good framework for that?
Oh, yeah. There's wonderful opportunities when you're doing primary care, for example, or even if you're doing psychiatric care. You're dealing with people that have either metabolic issues and obesity, and you can bring it all down to lifestyle. And there's so much lifestyle impact there. And how do you deal with that? So, okay, we've got to have a treatment strategy for this. You can prescribe medications, but that only goes so far. And so the real root of the cause is their lifestyle. So now you have a nurse practitioner, and she can or he can bill as a provider. So that's the main thing. And of course, every state's different in how they relate to reimbursement. But the main thing is that they're able to bill as a provider. The only main difference really is that they only get 85% of what the physician would get. But that's the case for all of us. Anyway, that's one way. And then if they're not a nurse practitioner, but it's a nurse that wants to get involved in lifestyle medicine, then it's like, okay, let's work with a provider, which could be a nurse practitioner or any other credentialed provider with the health plan, and say, okay, they will do the intervention, the lifestyle intervention. And whether it's a one-on-one, talking about diet, talking about exercise and sleep and stress management, things like that, having strategies, protocols, and curriculum to teach, or having a group, and groups are really good. You have a group class, it could be a shared medical visit, it could be just preventive care. So there's two ways to bill a group class. One is just an encounter of evaluation management, E&M visit, or it may be a group preventive care visit. And there are two different codes, but the group preventive care visit, if you have 5, 6, 8 people meet together, then you get something from each person, and it becomes pretty good as far as reimbursement over per hour reimbursement. And that could cover the time. Now, if it's a nurse practitioner, they can bill straight. If it's a regular RN, their service is incident to the provider that's available. And they could be available online, or they could be available in the same clinic, but they would be available. So that nurse is involved in putting that together. And that's happened lots of places. There are a number of clinics where the physician is wanting a class, like there was the CHIP program that was very popular. And so I know a friend of mine, she was a nurse in a clinic, and he had her do all the CHIP classes, and yet he billed for it. So that was a good way to go. That's really the two ways to approach it. So every nurse can be involved in lifestyle medicine if they really want to get involved in that. It's just working with either a private provider or being a provider in a situation that supports it.
Right. Thank you for that. So I heard you say for RNs, especially a curriculum kind of situation, or the group kind of situation, and being able to bill like that, and an incident too, if you're an RN and not an NP.
Right.
There were a couple things in the reimbursement roadmap I wanted to ask you about specifically, and that would be things like the CCM, the chronic condition management, and the collaborative condition management.
Okay, that's a really good area. And you can be, what that is, chronic care management. There's various ways you can call it. But anyway, if you have a wellness visit, for example, and at that wellness visit, you create a plan. That plan, or creating the plan, is a separate billing item in addition to the wellness visit. So it's up to 30 minutes you could spend creating that plan. And then usually the way we do that is we have people fill out a questionnaire, and then from that questionnaire, we create a plan. And that plan goes with also their treatment plan as far as any medications or treatments in the future. But it identifies, okay, you need to take this class, or you need to be seen by a dietitian or whatever. It just lists the things to do. And then once that's established, then each month you can call that patient and just talk to them about how you doing, and spend 20 minutes talking to that patient like a health coach, and get feedback on how well they're following their plan, answer their questions, things like that. And then that is billable. And then you can be doing that with all these patients. And it's just sort of a catch up. How are you doing? What's happening? And let's look at our plan and how you doing with that plan. And inevitably questions come up, issues come up, and then you have a lot to talk about. So it's you definitely use up that 20 minutes. And if it takes longer, you can actually bill more. It goes in another 20 minutes or 30 minutes. So it's another way to get reimbursed for the time it takes to really connect with people doing lifestyle medicine.
I have a couple follow-up questions to that scenario. The plan that is created with a medical provider like an MD, a DO, an NP, or PA, correct? And then we outline the plan. Then the one part of that plan could be an RN, a health coach, an MA, somebody else within the practice setting.
Calls them on the phone and talks to people and gets that feedback.
And so a follow-up question would be, let's say that goes on with a patient scenario for a bit, and that patient is improving their health. Are there any reimbursement incentives for the improved health? Specifically, not just the time that it takes for the RN or the NP or the MD?
Yeah, well, at this time, they're building these incentives. And right now, what we see is the quality measures that are out there. But if you're dealing with Medicare, the bottom line is, what is the expense of that person to the payer or to Medicare? So Medicare estimates that, okay, we'll spend, $11,000, $12,000 on that person a year. But if we can shrink that down to only anything less than that, then there's a savings from what was budgeted. And the way that they're trying to create incentives to where they'll give a portion of that savings back to the provider. And so that becomes an incentive to do these kinds of things that will prevent people from going to the hospital, because you're checking on them on a regular basis and encouraging them to make better choices with their lifestyle, which then again prevents a disaster. The medications, adherence is also another thing. You're working with their adherence, and that we know from better medical RX adherence, it leads to better outcomes, and better lifestyle choices leads to better outcomes. And so that's what the whole bottom line is. And that's where the incentives are. There's a Medicare REACH program. There's some other incentives, one that started this year or is going to start next year. Medicare is experimenting with new ways of incentivizing. But by 2030, Medicare is hoping that all providers will be reimbursed through these alternative payment models instead of just fee for service.
That's good news, I think, right?
We hope so.
What about if it's not a Medicare patient, though? Like, let's just say it's another third-party payer, like Aetna or Blue Cross or Cigna or something like that. Is the same thing in place?
Well, what's interesting is that the savings goes to Aetna or to Cigna or to something, the health plan, and they end up getting the savings. But this is where the fee for service idea. And I think providers, as they get more into saying, okay, I'd rather go with a capitated regular monthly income and then help these people do the best they can and prevent going to the doctors too many times and going to the hospital and things, reducing the cost. There's an incentive there when the provider gets paid for creating that benefit. And it's only a matter of time that all the healthcare systems are going to be kind of forced into doing this, because it's not good the way it's been going. It's just too much incentive for the health plan to just get paid more.
Right.
They get paid a lot.
Yes. So what does that mean exactly? Can you explain to us, if somebody would be listening who doesn't understand what capitated might mean?
Yeah. So you can get paid for fee for service. So everything you do has a payment. And so the incentive there is to do as much as you can, because then I get paid more. Okay. Whereas the capitated payment model is you're getting paid per member per month amount. It's like a fixed amount a month. It may be $50, $75, whatever. It depends on that person's health conditions they have. So a person that is obviously sicker, they're going to get more per month for that person than a person that's well, but they'll get so much per month. And then at the end of the year or whatever time frame, there's money comes back to the health plan or the health, in some cases it's a health plan, but when it comes to the provider, it's an incentive for the provider to then do more. And that's the emphasis of why they're moving in this direction, to create the incentives to help providers provide the best quality service with equity, and that way it benefits everybody. So that's the main thing.
Right.
So that's
Okay.
capitated. So that's, I mean, it's just a fixed cost. But that word capitated is not really used anymore because it means there's a cap to it. But it's a monthly fee that could be more than that if the patients do well. And so it's not just capitated, it's more. There's other models where a healthcare provider it's called direct primary care, where they get paid a fixed amount by the patient. Instead of relying on insurance, they just pay directly to the provider a month to month, and they can see them anytime they want. And so some people get like a high deductible plan, and then they buy this on the side to then see their provider as much as they want. But if they have to go to the hospital, they have the big deductible plan that takes care of that.
Right. And is that similar, DPC, direct primary care? Is that similar to concierge medicine, or is that a little bit different?
It's a little different. Concierge medicine is having the insurance, just like normally you would have insurance to take care of your healthcare, but then you have more. So you pay additional on top of whatever you're doing in insurance. So the healthcare provider is going to get paid by the insurance. But with this extra monthly fee you pay the provider, you get more. So it might be more value. So you have more. I get a visit anytime. I can make appointments anytime, day or night. Or I get an executive physical once a year that has treadmill tests and all these things going on. And you get more. And that's really what concierge is, like a Gucci purse. No, it's a Gucci healthcare. So it's on top of everything else. Whereas a direct primary care is you're just paying for care. You're not using any insurance.
Like cash pay almost.
It's almost like cash pay, but it's a monthly pay. So instead of paying $300 for a visit, you pay $85 a month.
Oh, right.
But you can go in as many visits as you want. Or
Right.
some $100 a month, whatever they charge.
Have you seen any difference in how much providers can leverage lifestyle medicine under any of those umbrellas? I know fee for service sounds like it could be a little bit harder to navigate through, whereas like DPC may not be.
Well, fee for service is where everybody starts from. So it's like you can do it in there because you can then, you have to be tricky because you want to see people more often. That's really the bottom line, because you're educating, you're teaching. You want to give them opportunities to learn and to practice their new skills, like in cooking or whatever. And if they are responsible for a copay, then that can get pretty expensive when the copay is $40 a visit. So they're not necessarily going to want to do that. But if it's a preventive care, then there's no deductible, no copay. And so for fee for service, that's what you want to try to use, is a preventive care visit. And there's two ways to do that. One is for obesity counseling. Intensive obesity counseling is based on the U.S. Preventive Services Task Force. It is a reimbursable preventive care benefit for most plans, and there's no copay or deductible required. So you just have to bill for that. It's obesity. Then the other is cardiovascular risk. A person is overweight or obese, and they have a cardiovascular risk factor. So it could be just family history, but it could be other things. Then they're eligible for that counseling. And that could be, again, 9 to 26 visits that would be for, again, lifestyle counseling, intensive lifestyle therapy, and have either a class or one-on-ones, but it's under that category, and that's considered preventive care. So there's no copay. So for the fee for service, that's where you want to couch your lifestyle medicine. If it's let's say Medicare Reach. Medicare Reach is where, again, you get a payment per month, and then you want to do all the things you can do to maximize these people's better outcomes. And so what you have to do is you stratify all your patients and say, these are the ones that are healthy and well. We only need to see them 4 times a year, and maybe send them a podcast and things that are simple. And then this group over here, and they are kind of in the middle of things, and we'll encourage them to participate in these exercise things that are going on. And you link them to those other kinds of classes. And then you have the intensive people that are chronic conditions and multiple chronic conditions. And then you want to get them into an intensive therapeutic lifestyle change program, group, shared medical visit thing that goes for like 10 weeks and then has follow-up for the rest of the year. So that's how you stratify your population, and then you're going to get the most benefit that way. And you'll end up not only getting your monthly fees, but then you'll get a bonus at the end of the year because you've saved all this money.
That's a great way to conceptualize it. I hadn't thought of that before,
Yeah.
but so I do have a question in that regard as I'm thinking about my own nursing career and who I've come across in the past. I know that there are RNs in particular, not nurse practitioners, but RNs who are doing some chronic care management of certain populations, like kids with asthma or kids with sickle cell or cancer, a certain kind of cancer. Do you think that we could structure, or is there a way, maybe it falls under the things we've already talked about, but for an RN in particular to almost be like a case manager or a population manager within a lifestyle medicine practice?
Yes, and that is a good way. If you have someone who is educated and really is a passion for lifestyle, then they are able to be that beacon in the practice. It doesn't have to be a nurse practitioner, but it could be the RN, and they could look at engineering that population, stratifying them, identifying who do I need to keep contact with. It's sort of a population management model. And then you can incorporate the chronic care management. You can incorporate doing these classes that they can help teach, and funneling through the healthcare provider, funneling patients to those things.
Okay. Yeah, I like what you said there about the population management model. I think that would be great for any RNs interested in lifestyle medicine. And
I know, and you get connected with a provider that wants to do this, and boy, they could have at it. And I think they'd love it.
There sounds like so many ways that this could be done.
Yeah.
Okay.
And the idea is just making it so it's sustainable. That's the main thing, sustainability. So you want that income. And what is important, a lot of times people are focused on, I want to just do this because I have a heart for helping people. So they do it. But you want to try to also get feedback on, are we getting reimbursed for this? So talk to the billing person and say, these are the things, the codes that I'm related to. So let me know if we're getting paid. Because if you're not, you need to think, okay, what are we doing different? What do we need to change? That's part of your survival. If people say, well, we're just not getting paid for you, so we need to cut budgets, so out you go. You don't want that to happen. So
right. No, you don't. So I do have a question in that regard. When you mentioned that, I'm wondering, RNs can, and maybe, I assume you're going to know this, but I'm thinking RNs can bill even an E&M code that's like a 99211, for instance. Like that could be a code that a nurse uses, but they may not want to if they're functioning in a different kind of way.
Yeah, because it pays so little. You get more if you could do it through the provider and then do a 99212 or 3.
And so I just want to check in with Deborah really quickly. Deborah, did you hear anything you wanted to ask additionally about, or anything that I maybe skipped over?
Thank you, Dr. Gobble. This is really important and helpful. I guess a couple of the things that we're really hoping to do here is what you have done, this body of work that you have worked through primarily for registered dietitians to really be able to, how to do this. Hospitals, they hit a little snag, they don't get reimbursed, forget it. This is what you really perfected. We're hoping in this hour that we have at LM 2023 to begin the process of sharing with our nurses. There are about 4 million nurses out there. We're lucky that we are providers, so we can prescribe. We have a lot of flexibility. But if I can just share a moment from the Future of Nursing report, it's the Future of Nursing 2020-2030, charting a path to achieve health equity. And it's basically stating that nurses are trusted bridge builders to champion health, and to achieve health equity, we need to have the systems that nurses function within to do more to allow nurses to practice at the top of their scope. They are educators. So we have a lot of nurses that are passionate and educating themselves about this. What guidance would you have for us in creating assets? We would love to do some of what you're doing there, but sort of targeted for the nurse, including some handouts that the nurse might bring to their small local practice or to their healthcare system, that is a beginning of the body of work that you're doing, but really targeted toward how they can utilize nurses.
Yeah, I think that's a good question. What could we take to the system to help enlighten the system? Just presenting the concept of how we can do counseling for obesity and how we can do counseling for cardiovascular risk reduction and for diabetes prevention, that these are areas we need to spend resources on. And so it's enlightening the powers that be, whether it's the provider or administrator or what have you, enlighten them that this is where we can shine. This is where we can shine, because we want people's lifestyles are what is driving them into these conditions. And so we can get reimbursed by helping them change those lifestyles, and just showing them the RVUs and how that RVUs is basically the relative value units. That's how they judge how much something is valued. And you can say, we spend this much time, this is what it's worth, and they want to do this for that institution or for that practice to make it a value. So it's just awakening people to this, because lifestyle is not in the black bag of most providers. They've got a lot of things to do, but they know it needs to be done. Anybody that's progressive or is new and knows that lifestyle is a major thing. And so they know it needs to be done, but it's like, I don't have time. So if someone else can do this, particularly someone as skilled and connected as the RN, then there's hope, and that's likely to drive it.
And that's so important, the point that you make, that the RVUs and how there's reimbursement for it. And your roadmap is amazing. We did go through that, and that chronic care management, the reimbursement there, and it indicates that it can be not only a really powerful for the patient, but also sufficiently lucrative, you say, to incentivize the practice, expand that. And then another part that you mentioned in there is remote physiologic monitoring. That looks like another option for nurses, collection and interpretation of physiologic data, and they get allocated up to a minimum of 30 minutes of time for that monitoring, but hopefully that would also be able to include education there.
Yeah, because you're basically, it's just feedback, and you're monitoring that feedback and then reporting anything that's high blood pressure. Okay, let's call that person back. Are you taking your medications? What's happened? Once you come on in, we'll make some adjustments. And you're on top of it. You don't let things go. That's what's nice about these physiological monitoring. And that's available. So all these things are all pieced together. A number of changes in reimbursement and since the last edition of the roadmap. So we're hoping that by this October, November, we're going to have a new revised version 3 of that roadmap.
Great, thank you. And also, there was a Z codes that you mentioned on the social determinants of health. Can nurses fit into any of that to justify that time that they're spending?
Well, right now the Z codes, these are codes that identify, like you found somebody that needs access to food or whatever, and you can have a Z code that defines what their need is. And right now those Z codes are really just for communication, to record what that is. But the assessment of social determinants of health, that's something that every health plan, every hospital, and soon every provider group is going to be required in order to keep their quality status up is to be assessing those. And so who's most available, who can help assess those and connect people to the resources they need as a result of that assessment. I think that the nurse is in a great place for that.
Okay, so that's coming. That's very, very exciting.
Yeah, social determinants of health. New, and it's new, but it's not new because it's lifestyle.
It's lifestyle.
Awesome.
And our passion is really to look at where everyone that's going to be there are lifestyle medicine, passionate, driven people. And then looking at from the lens of nursing and the National Academy of Medicine Future of Nursing 2010 and then 2020 now, and this real emphasis on those social determinants and saying, how do we merge these and say, well, everybody's important on the team, but nurses have generally been seen as on the expense side of the ledger for most businesses. So how do we move that over, and what can we bring to the table in that hour as assets and stories and expertise like yours to say, here's how we do it with the lifestyle and with nurses that want to really utilize the power of lifestyle to address that call by the national academies for us to address social disparities. Being in our infancy on this side, would there be specific guidance that you would give us as we embark on this journey to sort of following your footsteps for some guidance for nurses? And then also, would you recommend that we speak to some other people about this that you know from your vast years of practice out there?
Well, Dave Donahue is an excellent provider, and he is using nurse practitioners and stuff, and his staff and MAs and stuff doing chronic care management, remote patient monitoring, and trying to really capitalize on the lifestyle opportunities in a medical practice. We have in American College of Lifestyle Medicine the Lifestyle Medicine Practice Network, and everybody is trying to make this happen. And so we have things being put together as resources that would be useful. Caitlin Hawley in the American College of Lifestyle Medicine is really connected with what's going on with all the MIGs and how they can relate together. And I think we can connect and share resources to maximize the potential for doing lifestyle medicine successfully. American College of Lifestyle Medicine has got so many good resources. It's just amazing. More things coming out than we can keep up with.
Yeah. Even in the few years that I've been affiliated with ACLM 5 or 6 now, it is just amazing how much more information is out there. So, and I just did want to make a comment that you were talking about the new revised version 3 of the reimbursement roadmap coming out, and that's going to be October, November of 2023, correct?
Yes, we're hoping to have that out by the conference.
Oh, good. Okay. Anything else from you, Deborah?
Dr. Gobble, I think most of us feel very daunted by what you just dug into with the EMRs and the coding and everything. If there were going to be 1 or 2 resources that you would recommend for us to become a little more expert in or utilize, in addition to the content that ACLM has and Caitlin's expertise and all, are there 1 or 2 that are really clean? I think that actually you recommended also that you can sometimes talk to the there's like an insurance expert that may help with that. But would you say there are 1 or 2 places to kind of down dirty, quickly put together some facts that have to do particularly to a practice being able to utilize its nurses at their full scope in these settings, and then codes that they would utilize, a cheat sheet kind of thing?
Yeah, well, that's why we had the roadmap to help with that. And this next version, we hope to have clarified by profession as to what's relevant to nurses, what's relevant to physical therapists, what's relevant to occupational therapists, and so on. So that's going to be helpful. When we look at resources, there's things out there, but it's trying to piece them all together. You have the National Fee Analyzer. Okay, that's a book that's probably $150, but it has all the codes and how much is reimbursed kind of from the 50th percentile to the 90th and the 25th in terms of generally reimbursement for that code. And that gives you an idea of what charges could be made, what income could be made on some of that when you're making a pro forma. And that's another thing, is when you're trying to present this to an administration, you want to create a pro forma that says, okay, based on this many contacts and this kind of work, this is what you can expect. And that's a good way to talk to an administrator, because they like numbers. And that's where you can get a book like that. It tells you the numbers. The National Fee Analyzer, and they'll have one for each year. So the latest one will be 2000.
Thank you.
Thank you so much.
And if I can just follow up really quickly on that, the really amazing thing about what you just shared with us in this visit is that it's a win-win, because there are so many lifestyle medicine providers that would love to build this into their practice, and yet they're only able to build so much. But then they can take their nursing team and then build additionally and help their patients more. And really, just as you do with the RDs, bringing in these other teams, because ultimately our vision in lifestyle medicine is the vision of an integrated team. So how we're doing all of that, RDs and nurses and providers and exercise, physical therapists, everything.
Yeah, no one person can do it all. That's
Yeah.
so all healthcare is that way. We rely on the team, and it makes a difference. So it's when the team works together well, you've got a powerful advocate for quality care.
Yes. Thank you so much. I know you have spent a lot of time with us today, so I really appreciate it. Thank you so much for your wisdom. And
Well, thank
we
you
will.
this is wonderful, and nice to see you folks again, and we hope to see you again at LM 23.
You too. Yes, we will see you soon.